Thank you. I think the best way to introduce you to diagnostic imaging, and that would be computed tomography, or which is what I'm mostly going to be speaking about, and magnetic resonance imaging, is to show you one. So what is it? It's a three-dimensional X-ray. And like all three-dimensional imaging, you can look at it you can turn around, you can look at it in any plane that you wish. So here we're looking in the coronal plane. So I'm scrolling through the person from front to back, and I'll pause here to say, see anything you recognize? Some lungs, a heart, a liver, some small bowel, some large bowel, keep going. You can see the ribs, the different organs and tissues, a urinary bladder. We're getting into the hips down here. There's the hip joint. You can see beautifully, now we're getting quite far to the back of the body. Here's the two major flexor muscles of the hip, the psoas and the spine. And I'll scroll through this person back through their spinal column. There's a kidney, the diaphragm. So you can take this image, but you can turn it around, look in another direction. So over on this side, we're going to look at a sagittal view. So now I'm scrolling through the person from left to right. So this is the same image, same person. And here we're in the lumen of the lung. We can see the contents of the abdomen. We can see the abdominal muscles. People in nutrition don't usually learn anatomy, but you can recognize a lot of things that you know about in this picture. Now, about this technology, I'd like you to know that it's about 50 years old. It was originally developed by some British physicians and British physicists who were doing the quintessentially British thing with one another, which was drinking beer in the pub. And they figured out how to make diagnostic imaging, initially MRI and then computed tomography, which work on different physical principles. This kind of imaging is now, it's amazing. It's 2mm resolution, and it's ubiquitous on a North American scale. About 80 million of these images are done every year, and that's CT alone. Now I'm going to turn the guy around for a moment and scroll through him in the last direction. So this is like Humpty Dumpty, slices like a hard-boiled egg. I'm going down through his chest, through his heart. I just met the liver over here. Transverse colon. Kidney, muscles of the abdominal wall, and the paraspinal muscle groups. Now, where is this information? It's in every hospital. So 80 million CT images, North American wide, are accessible in the hospitals, in the healthcare services where these images are taken. So in your hospital or my cancer center, wherever you happen to work, these digital pieces of information are in an archived digital data repository, and open and closed, used and examined every day, and progressively over time. So if you're following a cancer patient, for which the scans are done to find the tumor and follow the tumor's response to therapy, you can flip through all the respective dates. So this is highly technological digital information which is accessible, widely used, and ubiquitous in the healthcare system. This is now regarded as part of the medical chart. And so when you, as a nutritionist, decide to go in and do research on these, that's considered a chart review. The image, I'm going to just touch on computed tomography, its application for body composition assessment. And as you might have already figured out, we're nutritionists, so we think about body composition as being global bone muscle fat, or possibly fat as subcutaneous, visceral, maybe intramuscular, but the resolution of this form of diagnostic imaging takes the resolution of the potential body composition analysis way over the heads of what we conventionally think of, because it has organ by organ, square centimeter by square centimeter, and indeed square millimeter by square millimeter precision and specificity on body composition of humans. So how does it work? You had an X-ray, a dental X-ray. There's a beam, there's a piece of film, your teeth go in between the film and the source of radiation. The radiation exposes the film. That's a snapshot. So in computed tomography, the source of radiation is in a donut-shaped gantry. The detector of the radiation is no longer a piece of film. It's a digital detector. The source of radiation and the detector of the radiation in the gantry spin faster than 3 times per second, taking snapshots all the way around while the person's body is spinning through the donut on the couch of the apparatus. So this means that thousands of individual snapshots are taken and reconstructed into the 3-dimensional image. I was going to show you the image here. So how does this work? Any substance has the property to attenuate radiation. So any atom, like iron or copper, if you put that atom in between a source of radiation and a detector of radiation, that substance will attenuate the radiation. That's a physical property characteristic of each atom. Likewise, molecules made up of different types of atoms each have a characteristic radiation attenuation value. And then the human body, every tissue, which is a composite of many different types of molecules, also has a characteristic radiation attenuation value. We measure radiation attenuation on an international scale, which is simply anchored on 2 famous substances, air and water. And on that scale, water is arbitrarily assigned the value of 0, and air is assigned the value of -1000. And those units are attributed to another British guy who spent a lot of time in the pub named Godfrey Hounsfield. So human tissues roughly fall in ranges in terms of their radiation attenuation values. Bones are very dense. Soft tissues like skeletal muscle have their own characteristic range of slightly less dense. And then adipose tissue is the human tissue through which radiation passes most quickly and easily. So what you're actually looking at when you see the picture is each millimeter cubed of the body has a characteristic radiation attenuation value. And that is simply transformed linearly into a grayscale. So the picture you see, the picture I led you through that has different levels of dark gray, light gray, and white are tissues with different radiodensities. So this gas in the person's stomach has a low radiodensity. The liver and muscles are darker, they're higher radiodensity. The bones like this vertebra and the ribs are white on this scale, reflecting their high ability to attenuate radiation. If I had to have passed physics to get out of high school, I would still be there now. And I don't know if that is true of everybody else in this room, but this is a marvel of physics and computer science. And I'm going to vastly simplify it for the purposes of today's talk. What I want to tell you about is about those 80 million CT examinations in North America this year, and the 80 million that were taken last year, the year before that, and the year before that are all digitally archived and accessible for the diabolical purpose of human body composition assessment. The indications for taking these images are many. So someone shows an emerge with trauma or abdominal pain. They will have a CT image. If it's an essential tool for planning surgery. In cancer, CT imaging is the base means of detecting tumors and following their progression over time. Inflammatory bowel diseases and bowel obstructions, as well as mundane surveillance for polyps, is now done with computed tomography. And for organ transplantation, CT imaging is a base examination for eligible candidates as well as eligible donors of organs. This is where this information comes from. And so these are all done with a specific medical purpose. And I'll just give you an example of this. Here's a coronal plane CT image taken in an oncology setting. And this person has got a funny looking thing in the lumen of one lung, which could be a variety of things. And in oncology, diagnostic imaging is now going in all kinds of different amazing directions. And one of those directions is you can also do a metabolism scan. So this scan was concurrently done with the CT scan. This scan, the person has been injected with a radioactive analog of glucose. So the picture you see is a map of glucose uptake in the person. The compound is eliminated by the kidney, so that's the urinary bladder. Glucose uptake in the brain, very prominent. And disturbingly, that thing, the mass in the lung, that very high glucose uptake. So the merger of these two images allows you to better visualize both the anatomic location of the tumor and its metabolism. Think down the road for nutritionists, the possibility of doing metabolic imaging as well as anatomic imaging holds great promise. So this diagnostic imaging was invented in the 70s. By the time the 90s rolled around, it was a group of researchers who were interested in obesity, aging, and diabetes surrounding a guy named Stephen Hounsfield at Columbia University, who decided to exploit diagnostic imaging specifically for human body composition. And Stephen Hounsfield and his group did an absolute yeoman's work of validating this methodology for this purpose. About 10 years ago, I and my research group in Edmonton thought, well, a little light went on that we could exploit oncological images for following cancer patients, and we've been doing that for about a decade. So what that looks like, and I'll just draw your attention to a publication which was first authored by Marina Murtsakis, who was a postdoctoral fellow in my group at the time, where we validated the use of diagnostic imaging to quantify muscle in cancer patients. And we had a considerable focus on the abdominal muscles, the rectus, oblique and lateral, abs, quadratus, psoas, and paraspinal muscle groups. And I'm just going to explain to you why we did that. These diagnostic images are very often not of the whole body. And it's become a convention in this perspective to take a single image to do the body composition analysis, which is situated in the axial plane. So this is an abdominal view, and the landmark or the situation of the image is at the third lumbar vertebra. And that was chosen to measure the muscles of the abdominal wall and the paraspinal muscle groups, annotated here in red, for the reason that this other group who did all the validation showed that there was a very strong correlation between the muscle cross-sectional area at this level and the whole body muscle mass of the same persons. And so that work, a little bit detailed here, was Shen's paper in 2004 Journal of Applied Physiology. They were looking at which single image you could evaluate to get your best estimate of whole body values. And you can see R² values in excess of 0.9 for total adipose tissue and in excess of 0.85 for skeletal muscle. So that's the rationale for looking at abdominal muscles. Now, I'd like to point out that a perfectly reasonable person with a grade 10 education could probably learn sufficient amounts of information about human anatomy, diagnostic imaging, and the software needed to assess this to be able to do this body composition work. So a nutritionist would have to do a little bit of an extra leg and learn the appropriate anatomy of the muscles in question, but that's not a huge reach, and there's good tools for learning that. The point you've done all this is the perspective you have. So here's 3 ladies. All 3 are, have metastatic colon cancer, and I've chosen them because they are identical in height and weight to one another. So there you can get a great impression. These 3 all have a body mass index of 30 kilograms per meter squared, and they have a quite different muscle mass. This is a median person, this is about the 25th percentile, and this is about the 75th percentile for muscle mass. So out there on the further edges of the distribution, they are more muscular and a lot less muscular than these 3 persons. I also compare them to 3 other ladies also with metastatic colon cancer from the same cohort to show you another amazing variation in body composition in contemporary Canadians. You can find any 3 persons, such as these, who have an absolutely identical amount of skeletal muscle, but slightly different amounts of fat, which helps you to understand that any aspiration you might have to use physical examination to determine the muscle wasting in some persons is going to be completely defeated by the mantle of adipose tissue that obscures that muscle mass from your physical examination and view. So then, once you can do that, you can put this all into a population. You have this is the last 700 consecutive ladies with solid tumors at the Cross Cancer Institute, Edmonton, and this is body mass index and skeletal muscle index graphs, so you can show that at any BMI, you can have absolutely any muscle mass, ranging from highly muscular to totally sarcopenic. Another thing I like to point out about the diagnostic imaging that we're able to touch on with this technique is fine radiodensity mapping. So here's 2 example people. You see a vertebra, you see the paraspinal muscle group. I've chosen 2 people who are of the same age, sex, diagnosis, blah, blah, blah. They're as identical people as I could find you in a cancer population. What I want you to understand about the fine mapping using the CT imaging, what you see colored in red corresponds to the muscle characteristics of a 30-year-old person in perfect health. What you see in the light blue would be visible fat, like marbling in a steak, and what you see in yellow and dark blue are some in-between areas of fatty infiltrated muscle. So here you can see, I'm contrasting for you a very good-looking set of muscles on this one patient and a very, very fatty set of muscles on the other. This fatty infiltration seems to be connected with nutrition, metabolism, diabetes, obesity, and importantly, many clinical outcomes, which is why we're very grateful to have this lens to see. Now, another encouraging thing is if you formed a picture in your mind of somebody locked in a darkened room painting up the muscles with a colored cursor, that's what we were doing. But this has also gone in the general direction of diagnostic imaging in the sense that it is easy to computerize. So you can train a computer to scroll down, find the right vertebra, and then find the muscle groups, do the annotations, and spit you out a set of numbers that tell you how much visceral fat, how much intramuscular fat, how much subcutaneous fat, and how much muscle that individual person has. And I think this is going to take us to where we are now in research. So you're the doctor, you call me, you want to know if your patient is sarcopenic. It takes me an instant to log into the imaging system. It takes less than 30 seconds for me to save the image in question. This algorithm will run in 90 seconds, and I could call you back, or have you wait in the phone line while I could tell you the exact body composition characteristics of your patient. So this is coming on. Now I'd like to mention that this has a whole bunch of technical parameters that are germane to the measurements that relate to the operation of the instrument and the way the images are taken. Not to enter into this in detail, but to mention that you have to understand diagnostic imaging and the way it's achieved in order to be able to properly interpret the body composition information acquired. And then I'd like to move just briefly end to end about the interpretation. So we take people and we see they have lots of muscle, a moderate amount of muscle, or if they have very little muscle, we want to label them as sarcopenic. And we do that by association of the low muscle mass with some kind of deleterious outcome. Likewise, we like to look at steatosis of the muscle that I showed you, the fatty muscle, or visceral obesity, which you can beautifully visualize with diagnostic imaging, and associate those with outcomes. And that's a work in progress. We're getting the data to define populations, and then we're starting to associate these values with outcomes. And there's a lot of different outcomes that you could consider, and we're only part of the way down the road in our ability to make these associations, just because the state of the discipline at this point in time. So now I'm going to just show you, here's a distribution, for example. This is a distribution of muscularity. So it's the muscle area divided by the height squared for a whole big bunch of people with lung cancer who happen to be of male sex. What I'd like to point out to you is this is a broad distribution, and that roughly speaking, the least muscular person has a third of the muscle of the most muscular person. And that's an important point. You're used to people having bigger or smaller noses, but I don't think you're really all that aware of people having bigger or smaller muscles, at least to that extent. So here's a couple teasers. When you know this distribution, you can take the distribution and align that distribution with an outcome. For example, mortality. And it turns out the relationship between muscularity and mortality, so this is risk of death on the horizontal axis, in men with lung cancer looks like this. So here you can see that there's always, going from most muscular to least muscular, always an increased risk of mortality with a rather steep increase as you get down into the really low muscle mass ends of the distribution. Some people like to make this into a bivariate using a statistical test to make a split into two classes. That's a useful clinical simplification. You can attend a great deal more work related to body composition and outcomes using these metrics. This is an example of our first big piece of work, now going back to 2008, showing that the mortality, so the survival of sarcopenic obese patients versus not sarcopenic obese patients, was hugely different in this medical oncology setting, independent of every other factor we knew to be associated with survival in this patient group. Another short teaser, we don't have this now, but there is a day in the future where I believe that in your clinical service, a dietitian will hand you a report like this. Your dietitian will be going in, entering the diagnostic imaging system, acquiring this data, and handing over a report indicating where any given individual sits in the distribution for a feature such as muscularity, as indicated here. That is going to move forward smartly in the coming years. And lastly, I'd like to point out that this is going to be used as outcomes in nutrition clinical trials. So here's an example of something going on at the moment in Canada. This is an interventional study using dairy products to maintain muscle mass in patients undergoing treatment for lung cancer. And the nutrition part is here. I'll leave that to you. It's a big dose of dairy-based nutrition, but I'd like to point you to the outcome, which is a change in muscle mass from baseline to week 12 using computed tomography. So this is accessible enough in the cancer patient's clinical record that you can already use it as the outcome of a clinical trial. So there, I just hope I've whetted your appetite to roll up your sleeves and become an expert on human body composition.
Great. Thank you.